Yep, so as I mentioned, we were looking at the complications of migraine, which, as you can see, is really hinges on what our initial definitions by the IHS criteria lah, as to what was a um, typical kind of presentation for each of the subtypes of migraine. As I mentioned, like just now, the headache usually in migraine usually lasts anything up to 72 hours. But now, in status migrainosus, we have a debilitating headache more than 72 hours. I also mentioned that the aura typically lasts less than 1 hour. And when your aura lasts more than 1 hour, it becomes a complication of migraine. That's why all these things are known as complicated migraine. Migraine with prolonged aura, persistent aura without infarction, or migrainous infarction, all these things are complicated migraine. So then you further divide into whether you see infarct on imaging or no infarct on imaging. So if there's an infarct on imaging, it becomes migrainous infarction. If there's no infarct on imaging, then whether it is less than 1 week or more than 1 week. If it's less than 1 week, it's migraine with prolonged aura. If it's more than 1 week, it's persistent aura without infarction. Migraine triggered seizure is where you get a seizure triggered by your migraine aura. As I mentioned just now, the pathogenesis of migraine is where you have like this wave of neuronal excitation, right? Leading to sensitization of the trigeminal vascular system. So now can you imagine a seizure is also similar, where you get this uncontrolled depolarizations everywhere, like a spreading wave, uncontrolled depolarization. And indeed, in your migraine, because probably migraine and seizures share a common pathogenetic process, they can, a seizure can be triggered by a migraine aura lah. Right. So, what are the clinical features of your migraine variants? Note most of these migraine variants are some are very rare, some are rare. So, I didn't really go into like that much detail. I'll just briefly run through. So there are bacillar type migraines, ophthalmoplegic, so on and so forth. The next slide we'll see. Bacillar type migraine, again it's rare. Classically happens in young women and children, and with the acute onset of brainstem or bilateral cerebral cortex kind of symptoms together with migrainous headache. So brainstem symptoms will include vertigo. Sorry, I spelled it wrongly here. Yes. Tinnitus, your 8th nerve lah. So your 8th nerve, vertigo, tinnitus, decreased hearing. Ataxia will probably be the cerebellum. Altered consciousness will be the RAAS in the arising, which is the group of nuclei which projects to vast areas of the cerebral cortex from the medulla pons and I think midbrain also. I've forgotten a bit of the neuroanatomy, unfortunately. Dysarthria will probably be, I guess, the 7th nerve. Dysarthria again doesn't localize it to brainstem. As you probably know, dysarthria is not a localizing sign because it can be due to cortical problems as well. Bilateral cerebral cortex symptoms will be like visual disturbance. Classically, the visual disturbance of a bacillar type migraine, as opposed to your typical migraine with visual aura, is that in your bacillar type migraine, your visual disturbance is both temporal and nasal. Both temporal and nasal hemispheres are affected, which means that it's probably a problem in the occipital cortex, as opposed it's a problem in your bilateral occipital cortices, rather than that of say like something which is homonymous, which probably means like a problem within the parietal lobe, whereas the visual pathways sweep through there or it's probably the temporal lobe also, as the Meye's loop goes through it as well. Bilateral paresthesias also are reflective of bilateral cerebral cortex involvement. Something small, bacillar is actually a misnomer because symptoms localize outside of the territory of the bacillar artery. So like bilateral paresthesias will be one example. I don't think the bacillar artery supplies the parietal lobe. Ophthalmoplegic migraine, it's rare. Again, It's when, simply put, as I mentioned, you get the paresis of the third, sixth, or fourth cranial nerves with migraine. Classically, this migraine is of a long duration, more than 1 week, and recently they actually don't want to call it ophthalmoplegic. They don't want to classify it as a migraine anymore because they believe it's actually a demyelinating disorder. They classified it as a cathalalgia under the International Headache Society 2004 classification. Retinal ocular migraine, otherwise known as retinal migraine, otherwise known as ocular migraine, is again rare. When a patient gets monocular scotomata or blindness less than 1 hour in duration followed by a migraine. As I mentioned just now, certain diagnostic dilemmas can occur with when aura comes in a weird temporal relationship with regards to the headache. As I mentioned, usually the aura lasts for about 5 to 20 minutes, then after that they get headache lasting less than 72 hours. But in this case, in migraine aura without headache, they get the aura, but the headache is either very mild or doesn't bother them at all. So they get isolated aura without a headache. And indeed, this can be confused with a TIA or stroke because they can get like weakness. They get weakness lasting then maybe less than 24 hours, you think it's TIA. Migraine with acute onset aura is when your aura develops in under 5 minutes. Again, it can confuse with TIA or stroke, particularly a hemorrhagic stroke because there's pain, you see, after the acute onset aura. So let's say that he get acute onset aura of sudden weakness followed by headache, and he isn't able to tell you, the patient isn't able to tell you which one really came first because it all came so close together, then you might think it's a hemorrhagic stroke. Maybe you might even think it's SAH if his consciousness is depressed. Migrainous vertigo is another migraine variant. It's a diagnosis of exclusion because you need to rule out Meniere's and brainstem disease in any case of an acute vertigo. It's when a patient gets episodic vertigo plus history of migraine or other clinical features of migraine, such as photophobia, phonophobia, or aura. So in other words, what I was saying is that in order to diagnose migrainous vertigo, you need to do some form of neuroimaging, either CT or MRI. Okay, so now, what are the investigations we do with migraine? Well, there's actually no specific investigation to diagnose migraine per se, because, as I mentioned, migraine is a clinical diagnosis, and we diagnose migraine actually using this thing called the International Headache Society diagnostic criteria to diagnose migraine. I have included a link to the website here. Please make sure that before we diagnose our patients, we have a look at the criteria and kind of like refresh our memory so that we don't diagnose somebody with a tension type headache as having a migraine, or worse still, saying that somebody with SAH has migraine. So check out the link, but please, I don't know, if you're a fan of memorizing things, then please go ahead, but I don't think I want to memorize every single bit of the criteria because it's online here. Radiologic imaging by CT and MRI may be helpful when you're in doubt of your diagnosis. For example, just now I mentioned when you get maybe a migraine aura without a headache, or migraine with an acute onset aura, this might be helpful. What are the specific indications for radiologic imaging in somebody with migraine? This was actually given by the American Academy of Neurology, published in the year 2000 in Neurology Journal. Apparently it's evidence-based guidelines. So it's patients with an unexplained abnormal finding on neurologic exam. So maybe the guy suddenly got weak, and then with headache, and you don't know why he got weak. Then of course you want to check the weakness. Why you must confirm. It could be a TIA for all you know, it could be a stroke, because stroke can frequently occur with migraine. Migraine can cause stroke. Headache can be coincidental with stroke, and many other relations exist. You see, so we need to confirm. Patients with atypical headache features or headaches that do not fulfill the strict definition of migraine should be imaged